everyone. Welcome to the Black Health Podcast. We are so excited to have this special episode today. We have wonderful guests today, and we are going to be talking about a really important issue, which is advancing maternal health equity through preventing pregnancy-related deaths in Georgia and across the country. My name is Khadija Amin, and I am one of the co-founders of Black Health, which is a Black-led, Georgia-based nonprofit focused on advancing the health and well-being of our communities through equity-centered advocacy, education, research, and programs. And we are really honored again to have our special guests here today to talk about this topic. But before we get a little serious, we want to break the ice, so I'll pass it to Mercy for an icebreaker.
Yes, thank you all for being here today. We're so excited to have you. And so I'll get us started, but we're just going to do a brief introduction. We want you guys to share your role and your go-to dessert. So ponder on that for a second. That was really hard for me. I really had to think about it in advance. But my name is Marcilla Ryan Harris. I'm the co-founder and director of operations at Black Health, but everyone calls me Mercy. And my go-to dessert, it's really hard because I'm very situational when it comes to desserts. But I would just say my latest obsession has been those little Cuban pastries called pastelitas. I think I'm saying it right. I might be saying it wrong. They're like guava and cream cheese in the middle, and it's all flaky on the outside. And I have it's this little Cuban bakery off North Druid Hills that I have been frequenting. They might know my name by now because I've been going in there, and they're so good. So that is my current go-to dessert. And I will pass it to Kristina.
Okay. Hello, everyone. I'm Kristina Tarr. I'm a labor and delivery nurse here in the Atlanta area. And I would say maybe a couple of my favorite desserts. I really love crumble cookies any day of the week. But if I'm at home, just maybe a brownie, a homemade brownie, and vanilla ice cream.
Yeah.
All right. Awesome. All right. What's good, everyone? My name is Remington Rolé. I'm community event manager for Black Health, as well as a health IT professional. And my favorite dessert, you really got me with that question. I would say the safest answer for me would be red velvet cake. Can't go wrong with that.
That's fair.
But I love insomnia cookies. I love cookies and cream. I love cookie cakes. So. I like a lot of desserts.
Cookies.
But yeah, I'll go for those.
Very good choices. Hi, everyone. I'm Dr. Natalie Hernandez Green. I'm an associate professor in the Department of Obstetrics and Gynecology at Morehouse School of Medicine and the founding and executive director of the Center for Maternal Health Equity. But my most important role is being a mom to two beautiful children. My favorite dessert is anything that comes with ice cream. Every time I see a menu, if there's ice cream associated with the dessert, that's the one I'm getting because I just love ice cream. But I like to mix it up with a cookie or some type of pastry.
Yummy. And hi, everyone. Again, my name's Khadija. I do like ice cream. I don't like sweet things, though. So I would say cheesecake because it's basically savory.
Like a little sweet, not
Yes.
too much.
But ice cream is good. I do love Jenny's.
Yeah.
Shout out to Jenny's.
Jenny's is great.
Yeah.
Almond butter, brown butter, almond brittle. Yeah.
Or the cranberry crisp.
Yeah.
I like that.
Good.
Yeah.
We might have to make a Jenny stop after this.
Yes.
This sounds like the dessert podcast.
Yeah.
Right.
Awesome. Well, let's get started with our conversation. And I wanted to start with a statistic, which is that more than 80% of pregnancy-related deaths are preventable. And we know that in Georgia, we consistently lead the country in pregnancy-related deaths. We also know that Black birthing people are disproportionately impacted. So I wanted to start with Natalie. If you could share a little bit more about the current maternal health crisis that we're experiencing in Georgia and why Black birthing people are disproportionately impacted.
Yeah, thank you for that. And thank you for, setting a little bit of the stage. But as you mentioned, Georgia ranks at least on the lowest when it comes to maternal mortality, um, deaths, and severe maternal morbidity. Because I think maternal mortality gets a lot of attention, but for every maternal death, there are 50 to 100 women that die that suffer from severe pregnancy-related complications. A lot of what's happening in Georgia is not new. The disparities and inequities that we've seen in maternal health have been happening for hundreds of years. It's just that there's been a lot more public attention to what's occurring. 87% of deaths, according to the latest maternal mortality review committee for the state of Georgia, are preventable. And so that means that there is hope that there are things that we can do to prevent maternal deaths. I think some of the factors that I like to highlight, because it goes in line with some legislation that we're seeing, is that Georgia also has one of the highest rates of uninsured people in the country. There's a high percentage of reproductive age women, which is about 14 to, depending now, 45, 47, that don't have health insurance. We also have a low proportion of reproductive health needs that are being met by publicly available health services, low attendance of postpartum care visits, high proportions of households living in areas with concentrated poverty and disadvantage. In Georgia, almost 40% of counties are maternity care deserts, and additionally, 76% of counties have no hospital or birth center offering maternal care. So there's a lot when it comes to social determinants of health that contribute to the maternal mortality crisis that we're seeing, and particularly for Black women. There is also a growing prevalence of chronic diseases, and so, obesity, diabetes, heart disease likely contribute to the maternal mortality rates that we see. Also, like myself, women are having children later in life than they used to, and some of us have more complex conditions when we're ready to have children. And we see that there are higher maternal mortality rates among women aged 35 to 39 and over 40, which increases your risk from 2 times to almost 17 times more likely to die from pregnancy-related complications. But something that's often not talked about and that we need to talk about is the interpersonal, institutional, and structural racism that contributes to the inequities that we see when it comes to maternal deaths. Because people would always say, oh, well, it's the social determinants of health. But we know, particularly for Black women and birthing people, social determinants of health are not protective. Because, I mentioned obesity. Black women who are of normal weight still have worse outcomes than all other women of racial and ethnic minority groups who are obese. Black women who are college educated still have worse maternal death outcomes than white women who drop out of high school. So again, yes, there are all these clinical factors, social determinants of health factors, but there's also racism that's contributing to what we see when it comes to inequities in maternal health.
And thank you for calling that out, how racism really structures our opportunities and access.
Absolutely.
Yeah. And I wanted to pass it to Kristina. As a labor and delivery nurse, you engage regularly with Black birthing people. So what are some of the unique barriers that you've seen Black birthing people experience when seeking care, when in care? And what does that look like, particularly in Georgia in the South?
Yeah, thanks, Khadijah. I think just to build on what Natalie has said, highlighting, the various factors that contribute to maternal mortality in Georgia, I think there's a real fear really around entering the space of pregnancy and labor and birth in Georgia for Black women, right? If you're kind of hearing statistics like this and hearing about a maternal mortality crisis, and if you're, a Black woman entering that space, you might feel like, oh man, like what's going to happen when I enter this hospital? Or am I going to make it out, on the other side, and be alive, be well, and like for me, before I became a nurse, I became a mother, and so I didn't really know as much as I do now about the whole process. But knowing about the maternal health crisis, I did make decisions to kind of try and prevent certain outcomes for myself. Like I sought care with a midwife group, right? I intended to give birth at Atlanta Birth Center. So, there were complications I experienced where I had to go to the hospital, but just my knowledge of, the crisis, I wanted to try and make decisions that would hopefully, go in my favor. I think also as Black women seeking health care, for pregnancy, we ultimately want to have providers that look like us, right? There's not a lot of OBs in the state of Georgia that are Black or are people of color. And I think that is a real, does a real disservice to Black women. Like we want to feel comfortable. We want to be able to communicate, without maybe like an area of like discomfort, right, with our provider. We want to be seen, we want to be heard and trust our providers. And I think that helps a lot when your provider looks like you, you know. And then, as a nurse, I take care of a lot of patients, a lot of Black patients from all different backgrounds, and have a number of health issues that they're navigating. Some are, totally what we call uncomplicated, but some of our Black patients have a lot of comorbidities. So, things like heart disease, hypertension, diabetes, obesity, things that they have developed prior to becoming pregnant, due to a number of factors that we could get into, social determinants of health. But then, entering into pregnancy, now, maybe there are pregnancy related complications that are compounded onto that. And so having to manage that with my patients, when they're in labor in the hospital, through medications, or really just, making sure that I'm there for them every step of the way, and making sure that, when I walk into the room and they realize that I'm the nurse going to be taking care of them, that hopefully they feel a bit more at ease.
Yeah. Thank you for sharing, and thank you for bringing in your lived experience as someone who's been pregnant, who's had a baby, and how that influences how you show up as a clinician, and also your decision making in your birthing process. And speaking of lived experience, we have two new and expecting parents with us as well. So we want to uplift more of what that day-to-day experience in your pregnancy journey looks like. So I'll start with Marcilla. If you could share a little bit about your pregnancy journey so far, and want to be positive. So what's been really rewarding, and then if there are any challenges as well.
Yes. So if you are watching this podcast, surprise, this is my pregnancy announcement. My pregnancy journey thus far has really been very chill. Like first trimester, I was in the trenches. That exhaustion was like nothing I've ever experienced before. I know people talked about it, but until you feel it, it's just like, wow, I really slept 12 hours last night. I woke up, moved to the living room, and now I'm about to take a nap. Whatever energy I had is gone now just from that short migration and nausea, but nothing super terrible. Kind of subsided around like 9 weeks, so I was thankful for that, but just didn't have an appetite. But since I've entered second trimester, I'm in what they call the golden stage, I guess. So like everything's been great. Just adjusting to all of the things that are happening and just trying to prepare for this new beautiful role of motherhood. I would say the most rewarding thing so far has just been, I'm just in awe of like what a woman's body does during this process. It's just like, wow, like I'm really growing a life, and my body is providing everything that this child needs to thrive right now, even if it's draining me. But so I'm just really in awe of that. Like every day I'm just blown away by the things that our bodies do as women. And I would say on the other side of that, that's also the challenging part of it, is just because like, wow, things hurt. Pregnancy brain is real. Like I lost the remote for like a week, and then I found it in the freezer. And I'm just like, I don't even know how did that, okay, whatever. Like, I don't know. Pregnancy brain just throws me off all the time. So I would say that's been the most challenging, is just like adjusting to all of the different things that come along with being pregnant. But I've been very fortunate that this has been a very like uneventful pregnancy thus far.
Yeah, that's good. I'm glad you found your remote.
Important.
Yes.
Right.
Can you share a little more about your experience navigating the healthcare system? So, with your healthcare team, how has that support look like? Have you felt supported?
Yeah, I think I'm in a very unique position, which I'm very thankful for. To Kristina's point earlier, a lot of people don't have providers that look like them, but I've been very fortunate that my entire care team is Black women. I've been a patient of this office since I was a teenager, so I'm very comfortable with all of my providers, and I trust them to really keep me in my health and keep me informed, to really look out for these risk factors and like understand just like the climate of Black women, especially in Georgia, and like what we're up against. And so I feel very protected by them. They're always, I see them a lot because I am advanced maternal age. So between my OB office and my maternal fetal medicine specialist, I'm at the doctor like every 2 weeks, just to make sure that everything is progressing the way it should, that I'm healthy, baby's healthy. So I really do appreciate having that support, and it's not lost on me that so many women aren't able to access that.
Absolutely. Yeah, and I appreciate you and Kristina mentioning the importance of having providers. Natalie, you mentioned this too, having providers that look like you when navigating care.
Yeah, it really makes a difference because it's even just like the small cultural nuances. It's like I don't have to explain things. It's like, girl, you gonna have your hair braided for labor? Because I'm like, yes, actually, I will. Because who wants to be bothered with that? So, it's like those little details that like I can talk about with my doctor and it not feel weird, or like it's really very like, hey girl, like how you feeling? What's going on? Like, let's talk. Like, what questions you have? So it's a very comfortable space. And then I don't know, it's just something very comforting about walking into an office and everybody in there is Black.
Yeah.
It's just like, oh, this is my safe space.
Yeah.
So
But also shout out to us being in Atlanta,
yes,
because I know
absolutely.
folks in other places across the country in rural areas don't have that privilege.
Yeah.
In terms of having providers that look like them, but even having like a full care team of OBs. Yeah. So I want to pass it to Remy. If you could tell us about your experience being a father and your partner, what her pregnancy journey was like.
Oh yeah, for sure. Well, first off, I don't know what camera I'm on, but as you can see, I'm a little excited to be a dad. So our baby boy was successfully delivered in Emory, Decatur about 3 months ago. So still in these newborn trenches. Still trying to adjust back to kind of being outside again. Just with everything that comes with just being a new parent with our firstborn. It's been quite a journey. No day is the same. Just when you think you got a routine down, a new thing arises, something's different. A position that he liked yesterday is now a little different. So it's been a journey, but it's been a labor of love for sure. He's a junior, so Remington Allen Rolé Jr. We call him Rari because initials are RAR. But he is literally like our whole world right now. And just with the whole process of him getting here was just such a learning curve for myself. My wife is a doula. She also has an MPH. She's a program director at a healthcare company in Buckhead. So she was like 10 steps ahead of the curve, like when it came to everything like child related. Like for me, people would ask, have you ever held a baby? I was like, what position would I ever be in to just hold a baby? Like hold someone's like random newborn? No, I've never held a baby. So I had a lot to learn. But with her being so well versed in the public health space, and also being a birthing doula, it allowed me to kind of get a one up on, I feel like, on other dads, right? So every step of the way, she took me to all the classes. I went to every appointment. We had midwives come to our house to kind of teach us, like, simple things like you would never think about, like how to put a car seat together, how to put a baby in a seatbelt, how to change diapers, just the whole process of kind of just learning those things, but also allow me to kind of just really lean in, because I'm a project manager by trade, so I kind of just want to learn step by step. So I'm asking questions like, okay, like this is the inception, here's where we're at, we're executing, like, no, how does it look after the fact? So I annoyed every midwife in every appointment that we talk with, just trying to learn as much as possible, right? Just learning about the different, station levels that a baby has to kind of progress through to be able to be pushed out. Learning just the different, signs in the hospital, just to make sure I could be the best advocate for my wife as she's going through the birthing process. So I just leaned all the way in. That was the best thing I felt like I could do for my partner, because I'm not the one who's pregnant, she is. So just being able to be as present as possible, be her biggest advocate, her biggest champion in the hospital, to make sure that we have a successful birth. And 3 months later, here we are.
Yeah.
So
I love that. And you mentioned your partner's a doula, so her having all that knowledge
for sure,
really helped you feel equipped to advocate
absolutely.
for her.
Yeah, it allowed me to just, know her brain of what she would want, and also, being her husband, kind of like champion that as much as possible, to make sure that, with all the pain and all the things that she's going through, she's not in necessarily the right headspace to kind of like speak to a doctor. That I was like, I already know exactly, like, how things are progressing. We've talked about this before. Like, we submitted a birthing plan, and just, kind of studying that like it's Bible and understanding that, how things kind of progress. If this happens, then, this is the course of action we're going to take. So just being able to kind of just know those things, have the education and the knowledge to, really lean in on that. Because I feel like, outside of being a millennial dad, dads of the past kind of just always talk about this kind of era as just being like, oh, it's a blur. I maybe changed a few diapers, but I didn't really get like a lot of insight of like what like the birthing process looks like, of what, labor looks like, even like what postpartum looks like. So like that entire, journey as things have progressed through different phases. I just took the opportunity to kind of educate myself as best I could.
Yeah. That's awesome. That warms my heart hearing that.
Yeah, she got me well prepped.
Yeah, that's good.
she prepped me for sure.
Yeah. I have a follow-up question for you and Marcella. Now that you are in your pregnancy, postpartum journeys with your partner, is there anything you wish you knew beforehand, before ending your journey? So any knowledge or tools or resources you wish you were equipped with?
I just wish I just knew a lot more about pregnancy in general. I think, I think women try not to talk about what happens during pregnancy because they don't want to like scare you from like getting pregnant. But there's this content creator on Instagram, and she's like started a series of like things I wish I knew before I got pregnant. Like, and she's going down the alphabet, and every single one of those, I'm like, girl, yes. Like, no one told me that I would just be randomly congested and getting nosebleeds like throughout the day, or just the small changes like that. But even just like questions that I should be like asking my providers. I think a lot of times we put so much trust in our providers. So it's like they come and they say, this is this. And it's just like, okay, cool. But like being prepared with just like different questions that you should ask at like different stages of your pregnancy, different weeks. So like I've been reading a lot of books. I got the pregnancy Bible, the what to expect when expecting. And so they've made some updates to it. So now they have like a little section after like each trimester of like, this is what to expect at your doctor's appointments. And like, these are the questions you should ask your provider. So I'm always like going in there with like a little checklist, like, okay, asking you about this. It's like, especially when you go in for your ultrasounds, it's like they just rubbing on you and all this stuff on the screen. I'm like, what am I looking at? You clearly see some stuff. They're just like, oh yeah, I'm just checking your blood flow, and I'm like, girl, is that good or bad? Like,
Let me know.
right? Tell me something. Like, what is happening? So I'm always like in there, like, oh, okay, so you said that's the placenta. Like, where is this position? Like, is that going to be good? Is it blocking my cervix? How is that going to impact labor? How is that going to impact the baby? Like, I'm grilling them and they like, dang girl. I'm like, yeah, like I need information because I'm one of those types of people. Information eases my anxiety.
Sure.
So it's like the more I know, the better I feel about things. So that's just one thing I wish I knew, just like how to just like go into my appointments feeling kind of better prepared.
Yeah. Oh, wow. I mean, just speaking to your point, even when Kiki was pregnant, every single day, it was something new. Like that I had no idea. I thought, like women having babies since like the dawn of time, like, like same old, but it's like, no, like there's so much you just do not know about what women can experience as far as like maybe like potentially like chipping like your tooth, eating like a pickle, like a jelly bean or something, or even like, swelling and having not only in your feet, but everywhere else. Like she wouldn't mind me sharing this. She had to wear like braces like on her wrist because at night like her wrists were like and hands would like swell up because how she would sleep. So it would be situations where it's like, what's going on? Like, that's a thing, like for real. But yeah, as far as like postpartum after RJ was born, that entire like 27 hours of labor that she went through, that was of course like life changing for her, but like just being a present partner and her husband, her best friend, that was like a lot on me as well to kind of see her go through something that was so beautiful and so painful at the same time. And then just everything that kind of comes with just the different stages, so like the contractions and how her body is like reacting to that level of pain. Even like with an epidural, is a situation where there's still a lot of like discomfort. And with our particular situation, it was kind of crazy because my wife, she's petite, she's small. I'm kind of big. I'm 6'4". So our baby boy ended up being on the big side as well. So he was born at around 9 pounds 22 inches. So with that being said, in regards to him being able to be delivered and come out, we ended up having to have an emergency C-section. And I guess in retrospect, after the fact, looking back on it, because he was a week late, he was delivered around like 41 weeks. We wish that we maybe would have went the route of planning a C-section. Like if we knew that he was going to be so big, because when we were in the moment and how the sequence of events that happened, first like her water broke before she was even dilated at all. So once her water broke, we had to go to the hospital, and then we had to go through the different phases of her being able to get to 10 inches dilated, for her to be able to even start the process of pushing. So once we finally got to the point where he could start being pushed out, because of how big he wasn't able to push down the necessary station level needed for him to be able to have a natural birth. And because her water broke so early on, like 16 hours ago in the process, that caused room for her to be susceptible to an infection, which then would cause a fever to raise the baby's heart rate, which would make it like a high risk delivery. So at that point, as all this is kind of going on, the midwife is trying to tell her to push, and she's realizing that, the baby's just not coming out. She had to go get the doctor. Doctor comes in and says, it's time to meet baby. Like we have to get this baby out. And he's just too big to kind of pass through. So we had to go through a C-section. And in our birthing plan, because, my wife's a doula, so she was prepared. She was like, we do not want a C-section, because that's just, scary, especially for Black mothers in the health care world. So we did not want a C-section. So just kind of seeing her face when it was like that was the option. It's like the air just left the room. I had to kind of just really lock in, pray over us, pray over her, make sure that everything's gonna be all right, but also internally just know that like, wow, this is like the last thing that we want, right? And anything could happen. But luckily, we were at Emory Decatur. It's a great birthing hospital here in Atlanta on the east side. So it was allowed for us to kind of, have the best team possible in the operating room. Like I remember, putting my little hazmat suit on, and the little bonnet and everything, and going in there. It was like 20 nurses, and every one of them had like a specific, role to play in the whole C-section situation. So once he was delivered, I got to hold him. So, that was an emotional moment for me. I don't usually cry a lot, but some thug tears came out. And just, holding my son for the first time. And then, I wanted to kind of like see. So like I'm holding her hand as just going like through the process. But I'm like, let me just kind of peek up my head over just to see what's going on. I'm like, oh my God. Like when they pulled him out, I was just like, wow, this is crazy. And then like, once he's like was cleaned and, weighed and everything, it allowed for, her to kind of just like reset. But then I'm holding him, but I'm also like, trying to make sure like, is my wife good? Like, y'all open her up. Like, like we got to make sure like everything's good. And then like, I saw the doctor just like, she's the definition of locked in. Like she was like going, just making sure everything was like clean and everything was good. Cause it's a whole medical procedure. I think it's downplayed. Yeah, it's really downplayed how like much like a C-section is like a major surgery. Because so many women, go through that process and have gone through it for so long, but it's an actual major surgery. Yes. So kind of just going through and being in a room for that was a lot, but just knowing that, our son was healthy, my wife is healthy, 3 months later, it just now is a whole memory that, is a day I'll never forget. But I do wish, all in all, just to answer your question, that if we had known how big he was, like in our earlier appointments, like we would have appreciated just, even though our birth plan said no C-section, like that be presented to us. So that way she won't have to labor for so long and be in pain for that long when it ended up being a C-section anyway.
Yeah. Thank you for sharing that.
Yeah, no problem.
I'll pause to see if Natalie or Kristina, as mamas as well, if there's anything else you would want to add about things you wished you knew in your journeys, even as experts in maternal health.
I wish I didn't know a lot about it because I think that's what makes you so fearful. Actually, yeah, I mean, I was also blessed to have, for both of my births, a midwife, a doula, a Black team of professionals. And I had 2 very different experiences. My first was a water birth in North Fulton, which I think is now Wellstar. And then my second was at AMC. And that, my water broke in the elevator, and 3 pushes later, my daughter was born.
Wow.
No drugs for both. So I was in a lot of pain. My husband wanted to stop for the first one. It's something about these boys that take a long time to come out. But yeah, I think sometimes we don't want to talk about the ugly. And we need to talk about that, right?
Yes.
I think like that storytelling and passing on these birth stories are really important so that we're not sugarcoating it. Like, yeah, it is freaking painful. Your body's doing amazing things, and there are risks associated with each decision that you make. And I wish that was brought up more than like the beauty part or even the breastfeeding part. Like that hurts. It sucks. Yes, breast is best, but like I felt like a failure for my first child when I couldn't complete it. That guilt that people put on you, that things are supposed to be this perfect and it's not. And then for me, I suffered from postpartum depression. And I knew my mom went through it. I wish she would have told me that she did, because it would have made me recognize it sooner and not have to feel alone and depressed for such a long time. Because I felt like I failed, like I'm supposed to be happy, right? And I was, but something was telling me that things weren't right and normal. So in Mercy, there is a Black version of what to expect when you're expecting. It's called Sis, You're Pregnant. And that's it.
We'll only include that in the show notes.
Get you a copy.
Yeah.
Yeah.
Kristina, how about
Yeah,
you?
I would build on what Natalie just said with I felt like I knew a lot about, or I felt mentally prepared and like going into like pregnancy and then the labor and birth part, even though like I said, I had some complications. I wasn't able to give birth at the birth center. I gave birth at AMC when it was still open. They had a partnership. Atlanta Birth Center had a partnership with AMC at the time. So the midwives had privileges there. So I just transferred there and was able to have a vaginal birth there. But I wish I knew about the postpartum period. I wish I knew more about it. Like Natalie said, breastfeeding is a lot more than you think it is. You know, it's not a casual thing at all. It's work. And I don't think I knew that. And I didn't know how demanding it would be on me, like on my body, on my time, like literally like you are that source of food for that person. They can't go to the fridge. They can't go to McDonald's. Like every 2 hours when they're hungry, you are their source of food. So you better be available. And that's around the clock. That's during the nighttime, you know? And fortunately at the beginning, I had a good supply where I could like pump and leave some. And then, you know, my husband could give her. But even then, like your body reacts to the fact that it's time to feed the baby. So even if I'm trying to sleep, I have to express. I have to get it out. Otherwise, I'm going to have issues. It's going to start hurting. And I developed issues with that, with borderline mastitis, like an infection, like clogged milk ducts. Like it was a whole thing. I had no idea about this, but I wish I knew more about the postpartum period. I did also develop symptoms related to postpartum depression. Like my husband recognized it. He was able to like get me in touch with a therapist, you know. I did have low moments like that, you know. So I wish I knew more about the changes that happen after you give birth, breastfeeding, and being mindful and like recognizing that, you know, you're not okay sometimes, and it's okay to express that and seek help.
Yeah. And the postpartum period is the part that's often ignored.
Yeah.
And that's actually where most maternal deaths happen, is that postpartum period. And so I'm glad that you brought that up, because I think people need to be aware of that, because we gloss over it. We're so excited about pregnancy, and then postpartum comes like, oh yeah, the baby's delivered, and all your social support is like gone with the, and you're just like, okay, what's next? And every month, like pregnancy poses a new complication or new situation while navigating your regular world.
Right.
Absolutely. Thank you for that transition. That's perfect. That's really helpful. And I mean, what I'm hearing across your stories, so thank you all for sharing your stories, is the importance of knowledge, and knowledge is power, to be able to make informed decision making, which is why Black Health has partnered with the CDC Foundation to share life-saving information around urgent maternal warning signs through the Hear Her campaign. And so I want to share some of those urgent maternal warning signs to look out for when you're pregnant, and when we talk about the postpartum period, so 1 year after pregnancy. So these signs and symptoms, this is not an all-inclusive list, so there are others, but they include a headache that won't go away or gets worse over time, dizziness or fainting, changes to your vision, fever of 100.4 degrees Fahrenheit or higher, extreme swelling in your hands or face. When we think about mental health, thoughts about harming yourself or your baby, trouble breathing and chest pain, severe nausea and throwing up, severe belly pain that doesn't go away, baby's movement stopping or slowing throughout your pregnancy, vaginal bleeding, so fluid leaking during pregnancy or after pregnancy, severe swelling, redness, or pain in your legs or arms, and overwhelming tiredness. So again, this list is not exhaustive, but if you are a pregnant person, postpartum person, if you are a loved one, a partner, someone who is experiencing these symptoms, it's really important that you talk to your healthcare provider And be sure to tell them that you're pregnant or have been pregnant within the last year. So I want to pass it to Kristina. If any of these urgent maternal warning signs, if you would emphasize any of these or add on to the list from your experience as a healthcare provider.
Yeah. So as a labor and delivery nurse, we have a lot of patients coming in with a lot of these warning signs present, right? It's bringing them into the hospital because they're concerned, because there are a lot of conditions that are associated with the signs that you just talked about. So I'll just kind of highlight a few of them that I see rarely common as a nurse. So preeclampsia, right? You talked about a severe headache that doesn't go away, right? That's a sign, right? Preeclampsia is also associated with a high blood pressure. So in terms of the numbers, it's a blood pressure that's higher than the top number being 160 and the bottom number being 110. So some of our patients are coming in with like a really high blood pressure. So that's something that we think about. It's also associated with visual changes. If you're seeing floaters, if you're seeing like spots or blurry vision, accompanied with that headache, accompanied with sometimes it can affect your liver. So pain under your right breast, because with a pregnant belly, that's where your liver is located now. And so if you're having that symptom as well, if you're having like a lot of swelling, yes, swelling can happen in pregnancy, but if it's accompanied by these different things, like swelling in your hands and your feet, in your legs and face, we are thinking along the lines of this could be preeclampsia happening. And so that would bring a patient to the hospital. They would have to have urine and blood tests to also further like confirm and diagnose that issue. Preeclampsia could be really serious. Usually a patient might need to be induced instead of waiting for labor to kick in naturally, or they might need to be on certain medications to manage it. Medications for their blood pressure or medications to prevent seizures, honestly, because preeclampsia, if it progresses, it can lead to a complication called eclampsia, which is basically all those symptoms and now the patient's seizing. So that's really serious. So there's a medication called magnesium that's given through their IV. That would be something that the provider might recommend to prevent seizures, and that's something that a woman could get during the labor process. And then a couple of the other symptoms or signs that you kind of highlighted there was a high fever. So a high fever is associated with infection. So say a woman's water broke and it's been a long time, like what Remington was saying, it's been broken for a long time and now she's spiking a fever. We're concerned about an infection, something we call choreo. And so a patient would have to get antibiotics. We want to monitor baby's heart rate closely, make sure baby's not affected, because baby's heart rate can also become higher than normal range. And now we're concerned, and now we need to try and get baby out, whether that's through induction or a C-section. And then you talked about pain in your legs. So pregnancy and in the postpartum period, especially after a C-section, we're concerned about the development of blood clots in your legs. So that's really serious, right? We want to be mindful if we're having those kinds of pains. Things like movement can help, being active, wearing like compression socks. If a patient's in the hospital, we can put a device on them to like squeeze their legs, because we don't want any blood clots, right, in the legs, and that can sometimes progress and travel to the lungs. And now we're concerned about that, what we call a PE, where we have chest pain and like basically the lungs are not getting blood and they're not being like perfused. So now we're really concerned. That's life-threatening. And then a couple other things you talked about vaginal bleeding, which is really concerning. Vaginal bleeding, we monitor it closely after a patient gives birth, because that is a period of time where a patient is at risk for hemorrhage. So checking the uterus, making sure that it's firming up, checking that the patient isn't bleeding too much. That's like the postpartum concern for bleeding. When you are still pregnant and you are experiencing bleeding, that's also concerning, right? If it's like darker red bleeding and then accompanied with sharp pain, like really sharp pain, we might be concerned that the placenta has now started to detach itself from the uterus prematurely. That is an OB emergency. That's like we need to get the baby out via C-section right away, because the placenta is what's giving the baby like everything it needs, right, when it's in utero. So if we have a concern, that's called a potential placental abruption, we need to get the baby out, right? So that's a sign of bleeding. Or if the location, when Mercy was talking about the location of the placenta, sometimes it might be too low and it might be covering the cervix a little bit, and then you see bleeding as well. That's also an emergency that we need to rectify as soon as possible. And then another thing that I'll just end on this, which you talked about, if you're not feeling the baby move as much, right? That's a big concern. In the third trimester, we want to educate our moms that they should be keeping track of how frequently they feel the baby move. Ideally, you want to feel the baby move at least like 10 kicks within a 2-hour period, and then just keep monitoring it, right? And if anything is outside of normal range, you want to tell your provider, right? Because we want active babies, and if there's a concern with that, you might need to go to the hospital and make sure baby is doing well and everything like that. So they're really important warning signs to be mindful of, and for all of our moms, just to make sure that mom and baby are doing well.
Absolutely. Thank you for dropping all of that knowledge. Natalie, would you add anything when we think about the data and those leading causes of pregnancy-related death?
No, I think you and Kristina with the urgent warning signs, I think sometimes what we try to do is make things so complicated when people just need information.
Yeah.
Like you mentioned, like knowledge is power. And we lack that, right? Because and I know we'll talk about policy, but there's no sex education or this type of training that, I'm not a millennial, I'm a little bit, but that I remember receiving in school that's not, in our generation is not afforded those same opportunities. And we try to overcomplicate things by making, and creating technology and thinking about AI and all of these other things, when we just need to give people what they want and the amounts that they need it and in the ways that they need it. And it's just as simple as that.
I love that. And Mercy, Remy, going down that list of the different types of urgent maternal warning signs, had you all heard of any of those before? What was, your knowledge around those warning signs coming into the pregnancy journeys?
Well, fortunately, I was aware of them before getting pregnant because of a wonderful Black Health event we had last year. But then once I got pregnant, because again, I'm advanced maternal age, and I also had high blood pressure before I got pregnant. So I have chronic hypertension. So I'm constantly being monitored by my physicians. And so every appointment, like those are the standard questions they ask me, like, are you experiencing any swelling? Have you been having any vaginal? They go down the whole list, like every single appointment. And so I'm happy that they're always like constantly looking out for those things. And then because I know what to look for, I'm also kind of on high alert for that as well. So like one day I had a headache and I was like, oh no, is this like a regular headache, or like, is this a headache I need to be worried about? And then it went away. So I was like, okay, cool. That was just like regular headache. So, and then even to that point, because I do have chronic hypertension, I am on medication to manage my blood pressure, which has been working perfectly, but they've also started me on low dose baby aspirin as a way to reduce my risk for preeclampsia, because that's just something that they're always kind of looking out for as well. And every appointment I'm giving urine so they can check for protein in the urine, which is also a sign of preeclampsia. So they're on top of it. And so I really appreciate that. And that makes me feel, again, just really like, okay, I can kind of relax a little bit because I have a care team that is really like checking for these things to make sure that me and baby are healthy.
Yeah, for sure. And to your point on that maternal health event, that was last fall. You know, being one of the individuals that helped organize the event, I was locked in. I was educating myself on everything that was there. My wife was actually able to attend while being around 10 months pregnant. So, you know, both getting the information, but while she was pregnant, you know, she experienced some of those symptoms like the headaches. She had to take baby aspirin. She had to take, you know, a form of like melatonin at night to be able to help her sleep, because that was just hard for her because she couldn't really sleep how she usually would, being pregnant. But yeah, there's a lot of those symptoms that you named were kind of just, you know, things that we were made aware of, whether she was experiencing them or through, you know, advocacy events that Black Health puts on.
Yeah. Awesome. Yeah, and Remy helped us with an amazing event. Natalie was there as well and central to that event around Black birthing people and just advancing equity for us. So yeah, we have clips of that event on both of our socials. So definitely check that out. But we talked about the barriers and some of the lived experiences, some of those warning signs. So we definitely want to end on what can be done about it and strategies for advancing maternal health equity. So I'll start with Natalie as the director of the Morehouse School of Medicine Center for Maternal Health Equity. You're really leading the country, the globe, and work around translating data and evidence into actions, systems change to advance maternal health equity. So can you share a little bit more about the work you all are doing? I think particularly when we think about policy systems change in Georgia.
Yeah, absolutely. And so I think I mentioned this earlier, but one of the leading causes of maternal deaths is around mental health conditions. And so previously, a lot of the work we have been doing through our maternal near miss story collection. So we've been collecting stories from women who almost died from pregnancy related complications. And when this happens, it's called the maternal near miss. And this is actually a more useful indicator than what currently maternal mortality review committees are doing. Yes, understanding causes of death are important, but listening to actually women's lived experiences and their stories are more powerful, and you can figure out different types of solutions. And something that came up through that was that trauma and the mental health components that we know, again, is one of the leading contributors to maternal death. And so through years of working with communities, seeing what the statistics are, we developed a project called the Center to Advance Reproductive Justice and Behavioral Health Among Black Pregnant and Postpartum Women and Birthing People. And this really gets at the three challenges that we're experiencing in the 21st century, which is the maternal morbidity and mortality epidemic, the behavioral health crisis, and intersectional discrimination. With this, we're training the next generation of researchers that would be in the field, working in partnership with communities, because that's really important for how we do our work and thinking about community organizing principles in that. And then also training that next generation, but then building community together to figure out solutions. And that is forged through also developing a research agenda that's informed by the community around behavioral health challenges that Black pregnant and postpartum women and birthing people are experiencing. One of our research projects is also looking at how laws criminalize Black women, particularly Black women who suffer from drug use. And we're analyzing the implementation of laws that govern drug use in pregnancy in the U.S. over time, with the focus on their implementation on Black pregnant and postpartum women. Because over and over we hear from women, oh, if I report that I use drugs, or if I report that I'm experiencing postpartum depression, they're going to take my children away.
Yeah.
And we know that that actually does happen, specifically to our communities and women. And so we're really excited about that. That's a 7-year funded initiative. We just finished interviews with key stakeholders, and now we'll be doing sessions with Black Mamas Matters Alliance and other community-based organizations around the state to hear more from the community and what they're prioritizing, and then doing some research around that. But again, not examining the root causes, but developing solutions to address them because we know what the causes are, right?
Yeah.
Another project that I'm excited about is our SOAR project. So in public health, we love acronyms. And so that one is supporting and advancing maternal health in rural communities because people forget about our Black sisters and brothers and that are outside of Atlanta.
Yes.
And we wanted to make sure that we were addressing that, and particularly with fathers. As Remington mentioned, he didn't know a lot, and we knew that Black fathers didn't know a lot. And so we've developed a project where we'll be training men as doulas and community-based navigators, and also giving them an influential role in centering pregnancy and with topics that are more related to what fathers want to know during pregnancy and a postpartum period. So that'll be launched next year at Grady Hospital. So we're really excited about that. And hopefully as a pilot that can be expanded across the country. Last two more that I'll highlight is our Project Impact. And one of the things that we kept hearing is that you never know when you're going to get pregnant, right? Most pregnancies are unintended. And so people need to be healthy before they're pregnant. And one thing that we know is evidence-based, and I put that in quotation marks because that's what we're trying to figure out, is preconception counseling. But that happens in a clinical setting. And we also heard that Georgia has the highest rates of uninsurance. So no one's really getting this information. And so we're meeting people where they're at, where we're training lay people to develop and deliver this preconception counseling that's personalized. And so they go through a screening, and depending on what the risk is, that's what people will focus on. And so this project is not just in Georgia, but in South Carolina, North Carolina, and Tennessee. And we focus a lot of our projects in the Southeast because 56% of the Black population lives in the Southeast.
Yeah.
So that's really important, right? These are models that are developed by us for us. And so those of you that are young understand the FUBU model. And again, it's very scientific, because one thing that we also hear is that HBCUs or Black people don't do work that is evidence-based, that it's this or that. And so we are very strategic in how we do that. And so it is, a clinical trial, which a lot of our projects are, but then a lot of our projects are a mix of recognizing that Black women's voices are legitimate sources of data, right? That there's a lot of information that's missing, and that our voices need to be amplified and centered in the way that solutions are being developed. And lastly, our flagship program, and we have about 15 projects, so I don't want to bore y'all with all of it, but these are just highlights, is our community-based perinatal patient navigation program. And this, again, we heard over and over that people lack social support, especially, our mamas who don't have the resources or are as privileged as we are, right? And so they lack that social support. And so we train lay people, particularly women and men who have these lived experiences as doulas, as community health workers, as patient navigators, and as lactation peer support specialists. And it's a comprehensive training because, again, when we think about policy, we want to know, okay, it's not just about providing support, but then it's also economic development for our communities because we pay people who serve in these roles as clinical care coordinators.
Oh, wow.
And so it provides economic opportunities that a lot of them normally wouldn't have because you need certifications and all of this, but we take a community-based perspective for it. And so women that go through this program, we're recruiting right now at 4 different places in FQHC, Atlanta Birth Center, Grady, and another hospital. And, people that need it, people that have high unmet social support needs get recruited into the program, and our navigators assess them. They provide social support. They provide that health education. They do group sessions. They meet them at their homes. We give them vouchers for transportation, food from the food bank, a whole bunch of stuff to make sure that they're a whole person, because this is a population that people push away. People, particularly those that go to Grady, don't get the support or the resources that you'll get at an Emory Decatur or Emory Midtown or a Wellstar, but they get really good clinical care at Grady. But we just want to go the extra mile and provide them some of those social supports. So a lot of that and a lot of our research then translates into policy and action. So how do we use all this data to move the needle forward? And so one of the things that we're really excited about that's happening around equitable maternal health policy is the possibility of Medicaid expansion, right? We finally see some bipartisan support on it, although it's, it's scary because we're almost at the end of session and we don't know how realistic this can happen. But I remain hopeful. Because I think even if it doesn't happen this year, then maybe next year, that there are these opportunities. We're learning from our mistakes. We're getting better organized. And we're making the case because it doesn't just affect Black people. It affects everyone in the state of Georgia. There's also a new bill that was proposed to protect free preventive care that was introduced. So Senator Halpern, who I love, with the support of 6 Republican co-sponsors, with this bill, it ensures that Georgians continue accessing life-saving preventive health services without facing financial barriers. And that's really important because we talked about preconception health and making sure that before people are pregnant, that they have the care and the support that they need, and that ensures that. And then there's been finally this recognition of the diversification of the perinatal workforce. Yes. And so doulas and midwives and community health workers, we're even getting close to, support around the certification for community health workers. Hence why we train our navigators as CHWs, because now if that passes, they can get reimbursed for those services, whether it's through that mechanism or as a doula, right? And they provide the essential services that our communities need. And then some stuff around fertility, because again, people focus on pregnancy and postpartum, but our women are struggling even getting pregnant, right? There are a lot of misconceptions. People just assume and push long-acting reversible contraceptions on us and don't want us to get pregnant. And by the time we want to do that, we're struggling to do that. And so we really support reproductive justice bills that support Black women and their fertility journey and being able to cover some services, but also make it easily accessible for them. And so that's just a little snippet of what's happening. Like I said, I always see the glass as half full, and I'm really optimistic about what we can achieve, particularly because I think our community's sick and tired of being sick and tired, and people are really mobilizing and holding their policymakers accountable. Because guess what? If you don't do these things to support your communities, you're not going to be in that office next time. And so I remain hopeful, and I hope that our legislators and people that are on the ground fighting remain courageous. When we look like the people that we're serving, we can make a bigger difference than some people who just follow what funding patterns are or, what's the hot new topic, right? Because I feel like now everyone's doing maternal health. But where were y'all 10 years ago when women were still dying, right? And women were still suffering. And so I'm really happy that, I'm always appreciative when people join it. It's just that we need to work better together and be on the same message with one another. Because sometimes people that come in the fight later on can make it really difficult for those of us that have been on the ground and in the trenches for a long time. So we're really grateful for the partnerships that we have. None of this work is possible without our partnerships. And we remain, again, hopeful. And I have a lot of faith that good things can happen in the midst of everything else that's happening in this country.
Yeah, absolutely. And I think leaning into where we can make state and local changes. And I know there's a lot of energy momentum around the CHW certification, around access to IVF treatment, and those made it through crossover. So
yeah, I know. That was oh, wait, they made it through crossover.
Yeah.
And again, amplifying assets, we've been doing this for a really long time. We know how to do this work. It's just a different topic, right? The civil rights, leaders, this is exactly what they did. They mobilized, they had the evidence to support what they wanted, and then they continued the fight. And again, I think that that's where we're at, in our data is our women's voices. It's although they cut prams, it used to be prams and other information that we would get. But we're trying to get it in a better way, in a way that's culturally responsive, in a way that can really impact policy, because we need to be at the state, we need to be doing systems thinking. Interventions are Band-Aids, right? But because you can create the best interventions, but if you don't change policy, then it's not going to really make the impacts that we need to make.
Absolutely. Thank you for sharing all of that. You all are doing amazing work, again, translating data and evidence.
Shout out to the HBCUs.
Into action, and really focusing on action, making sure it's getting out of the ivory tower. So thank you. Yeah. And I wanted to pass it to Kristina. When we think about the healthcare system and clinical practice, what are some clinical practice changes that you would want to see to ensure that Black birthing people, care partners have access to quality, affordable perinatal care?
For sure. So I would start by talking about like the clinical environment. And as a labor and delivery nurse, I would first start by talking about staffing. So we need better staffing for L&D nurses, better nurse to patient ratios, right? Because when we are short-staffed, which happens a lot at night, I work night shift, it's compromising care, right? And it's also contributing to nurse burnout, right? There are standards for how many patients a nurse should be taking care of at the same time. Those standards are really set by a national organization called A1, and it's a organization that kind of is the leading organization for OB nurses. All hospitals should try and meet A1 standards in terms of nurse to patient ratios, but sometimes it's just not happening, right? Especially like maybe at smaller hospitals that have less resources. So normally like a nurse can take care of 2 laboring patients, right? At the same time, but sometimes you have to be able to, sometimes like what we call acuity. So how sick or how much care the patient might need, right? If it's a higher acuity, they need a lot of care. Lower acuity, they might not need a lot of care. Or if they're earlier on in the labor process, maybe they haven't started dilating yet, or the patient just got into the room, we just started the induction, maybe like their needs are less compared to a woman who's 9-10 centimeters and we're about to have this baby, right? The assignment, like the nurse assignment, should be balanced, but sometimes it's not. So sometimes I'm running into room 11 and, this patient has a lot going on, or, the baby's heart tones are down and now I got to do interventions in the room. And I also have another patient, across the hall who might have a lot of needs too. She might need some pain management, right? She might have other issues that she's dealing with. She might have preeclampsia and I need to take a blood pressure. I give her medications. So sometimes the balance isn't there. And now I'm like kind of, being torn as the nurse, like balancing, prioritizing the patient's needs when both patients should ultimately be the priority. And that happens more times than I would like to say, and that's based on staffing. So I would say better staffing because as some women might know who've had a baby and been in a labor and delivery unit, you interact with the nurses more than you interact with the providers, right? So better staffing for nurses to meet the needs of our patients, our Black patients, all our patients really, but patients that have a lot of comorbidities going on, which is something that we see a lot with our Black patients. We also need, we talked about this before, we need more providers of color. We need more clinical staff of color, more Black nurses, more Black OBs, surgical techs, doulas, anesthesiologists. Like these are all providers and clinical staff who you would interact with at the hospital for labor and delivery. And it could just make the process better. You can communicate better. There maybe isn't that, like, you could maybe trust your providers better. You might feel more comfortable as the Black patient there in the unit. So more providers of color, more Black providers, I think would be a great way to, help this issue of maternal morbidity and mortality. Also, Natalie touched on it, but we live in Atlanta, but like, what about South Georgia? We need more providers in more rural areas of the state, and if possible, more birth centers, because a lot of women who are low risk could benefit from having a birth center birth. We just don't have a lot in the state. We only really have the one here in Atlanta Birth Center, and we might have midwives throughout the state, but birth centers are lacking, I think, in the state of Georgia. And then just another thing from the clinical side is when you think about providers, I think providers could do a better job at being more present for their patients in the hospital, listening to their patients, right? I talked about working on night shift. When you work on night shift, really, sometimes we don't see the provider the whole shift, right? Us as a nurse, we are like doing all the care, like performing all the care needs as ordered by the provider, updating the provider if necessary, if things are going left, right, or if it's in the event of an emergency, or if we're starting to push or whatnot. We're updating the provider, but it's us, the nurse, in the room, right? And the provider might not come into the room unless it's an emergency, or we see the baby's head coming out and it's time to have this baby, right? So I think and this isn't all providers, but I think a lot of providers could be more present for their patients physically in the hospital, especially on night shift. And then also, I think that clinical staff could benefit from more training. And I say, clinical staff, that could be OBs, that could be nurses, that could be our surgical techs, anesthesia providers, et cetera. Because I think that not everyone is in tune with the Black maternal health crisis, even if you work in maternal health, or they might not be in tune to things that they could improve upon in order to contribute to fixing this issue, right? I think that also clinical staff could be more mindful too when it comes to communicating with our patients, just being more compassionate as well, which sometimes you would think that maybe that's a given, but it's not a given. And then also advocating for your patients, right? I do that all shift, every shift, right? Sometimes you the nurse and the provider might not see eye to eye, or sometimes you want to raise an issue to the provider on behalf of the patient, and you have to step up and do that, because that could mean the difference between a really negative outcome or a really positive outcome for that patient. So advocating for the patient, being compassionate, and then just also being more aware of the issues of Black maternal mortality and morbidity.
Absolutely. Thank you both for sharing. So we talked about systems level changes, policy change. We talked about clinical practice change. So now we want to talk about that interpersonal level. So from expecting a new parent, what changes you all would want to see. So I'll start with Marcilla. As a Black birthing person, what is a piece of advice that you would give to other Black birthing people about urgent maternal warning signs around navigating the healthcare system?
I would say in regards to like urgent maternal warning signs, like listen to your body. Like even if it's not, even if it ends up being nothing, like get it checked out just in case. Because I would rather personally go to the doctor and they be like, oh no, it's nothing you need to be concerned about, then like wait, and then it turns out to become something serious that I could have addressed a while ago. So I definitely think listen to your body. Even if you feel like your providers aren't listening to you, continue to advocate, because when something doesn't feel right. So just always use your voice to advocate, and then also just building a support team, whatever that looks like for you. So if that's your partner, if you have a doula, I recently started working with a doula, and so I'm really excited for her. Shout out to her. She was one of our Black Healthcare Fellows in our first Atlanta cohort. But yeah, just having a support team, people who can advocate on your behalf, like Remy spoke about, like being there to speak on behalf of his wife when she isn't able to. I think that makes a really big difference. And then even navigating the healthcare system, like, don't be afraid to ask questions. Again, I know those power dynamics exist, and so sometimes we can be afraid to question our providers, but like, they're there to help you. And so I think we have to get out of that mindset that like, oh, well, this is what the doctor said, I'm gonna just go along with it. Like, don't be afraid to question anything that they tell you. So those would be my pieces of advice.
And to Mercy's point, there's just for listeners, there's this thing called the Black Birthing Bill of Rights, and that it addresses exactly that. Like, what are the types of questions, and knowing what your rights are in that relationship with your provider, because we're quick to like dismiss someone if we don't like the way they do our nails or our hair, but we're really hesitant when it comes to a provider because of those power dynamics. And I think the Black Birthing Bill of Rights provides some introspection on what those power dynamics are and how you can elevate and amplify your voice in that situation.
We'll make sure to also include that in the show notes. Remy, how about you? What advice would you give other fathers, expecting parents?
Well, as a Black father and a Black husband, I feel like you really have to dig deep and really pose the question for yourself. How you plan on leading your family? Because when it comes down to it, if you're not knowledgeable about what your family is going through, whether it's your wife looking to you to advocate for her in the hospital, or a partner looking for you to advocate for them in the hospital, or even after the fact when, you know, they're recovering from a C-section and, you know, they're unable to move, but the baby's hungry. So do you know how to put a bottle together? Do you know how to, you know, warm her supply of milk, or, you know, even supplement with formula? Like, do you know these things? And with knowledge being power, you have to be able to be really cognizant and understand that you have to know how to do these things for you to be able to effectively lead your family, because your partner's going to be looking to you, your wife's going to be looking to you, and, you know, your baby is dependent on you as a parent to be able to operate and understand that, you know, what this baby needs, you have to get done. And in the event that, you know, my wife or, you know, your partner is unable to, you know, be able to do these things, you have to be in a position to where you understand, you know, the tendencies and the different things that this baby is going to go through. So I would say that just kind of posing that question, like, how are you going to like lead your family when it comes to the pregnancy stage and even postpartum, and really dig deep within yourself to be able to, you know, put that first foot forward to get that knowledge, to be able to understand the different ins and outs, the different phases of what your family is navigating. I feel like that's like the most important step for you to make.
Absolutely. Thank you.
Yeah.
And thank you all. Every time we have a podcast or a conversation, I learn so much from our guests. So again, thank you for both sharing your expertise, but also your lived experiences with our audience. And again, we are so excited to be working with the CDC Foundation to share this life-saving messaging around urgent maternal warning signs and raising awareness about those warning signs through the Hear Her campaign. So our call to action for our listeners, our viewers, is to check out those resources online for the Hear Her campaign. Again, we'll make sure to include those in the show notes, but it's a wealth of resources and information around being able to identify those urgent maternal warning signs. And again, Black birthing people know their bodies more than anyone else. So if they are feeling something isn't right, it's so important for their partners, for care providers to listen to them. And it's so important to get medical care. So again, those resources are online through the Hear Her campaign. We'll link those in the show notes. Again, my name is Khadija, part of Black Health, and please stay engaged with us. You can follow us across social media at BLKHLTH. And you could also visit our website at blackhealth.com. Thank you.